him, but he cannot be here today, so I'm doing the job. So David Lansky is the President and CEO of the Pacific Business Group on Health. Since 2008, David has led the coalition of 50 large employers and healthcare purchasers representing over 3 million Californians, including CalPERS, Wells Fargo, Intel, Safeway, Chevron, and University of California. A nationally recognized expert in accountability, quality measurement, and healthcare IT, David has served as a board member or advisor to numerous healthcare programs, including the National Quality Forum, National Priorities Partnership, the National Patient Safety Foundation, the Leapfrog Group, the Medicare Beneficiary Education Advisory Panel, Cal eConnect, and American Health Information Community. He is now the purchaser representative on the Federal HIT Policy Committee. David holds a PhD degree from University of California, Berkeley. Let's welcome David Lansky.
Good evening, everyone. Thank you so much for letting me come and join you. I'm really excited to be in a group of people so creative, energetic, innovative, because a lot of where I spend my time is not that way. So I'm glad to have a chance to hear from you and talk with you. I wasn't quite sure what the right focus would be for what I should share with you tonight, so I put together the usual sort of presentation. And as you see here, it's a little bit of a David Downer. It's kind of why are the purchasers so skeptical about a lot of the work that you do, and why is it so hard to get uptake for innovative solutions to healthcare challenges from the people who have the money and the lives and the influence in the healthcare system, like the companies Prannoy just described. So I will do some of that, but I would also encourage you to interrupt me and take us off course and talk about other things. We could talk about the Supreme Court, and we could talk about health IT, which I didn't do much in this presentation, but it is, as Prannoy said, where I spend most of my time. And I wasn't sure how many of you were wedded to the health IT strategy, but I'm happy to get into that discussion if that's of interest. So let me thank particularly Prannoy for inviting me, and Jerry Hinckley and the Pillsbury folks for hosting this event. So purchaser perspective. So I thought I'd better start with sort of getting you oriented to the world I live in. This is an association of really big companies, and they employ many, many hundreds of thousands of people. And they provide healthcare coverage and benefits to all these people. And so what they have my organization do is essentially represent their common interest in affordable, high quality, predictable healthcare. And especially as you all understand, the last few years, affordable is the buzzword of greatest concern to them. And I'll talk some more about that in a minute. But here you see a lot of big name brands. A lot of these have a big California footprint, but most are national and even global companies. I just zoomed in here on this one group you may know, the Silicon Valley Employers Forum, which is in turn made up of all these companies, obviously many of them involved in technology and innovation and IT in particular. So all these companies are who I try to listen to and respond to when they think about what they want from healthcare. Not as a product that they're themselves developing, but on behalf of their workforce and their family members. So I thought I'd better ground you in sort of this ecosystem that I live in. And it's a really simple picture, but the basic idea is down there at the bottom are the providers, doctors, hospitals, clinics, nurses, that all of us mostly contact to get our healthcare services from. They are in turn getting their money and their access to patients from health plans in the commercial space, leaving aside the over 65 Medicare population. And over in the upper right are the secondary purchasers, which is my world. These are the large employers, like my members, but also the big government buyers of healthcare, like Medicaid and CMS, Medicare, and other programs in the federal government in particular that buy a lot of healthcare. And then over in the far left is the patient, the primary purchaser, who ultimately it's their money, and increasingly it's directly their money, that's going to pay for everything else. And the reason I put this up was just to sort of both tell you where I sit on this picture, which is this upper right-hand corner, and you notice that we are mediated by the health plan. Most employers don't directly communicate with providers about their healthcare solutions or about the technologies they will invest in and buy to support the patient. The health plan is the direct channel, and that's a very important part of the dynamic for where my community lives. So I thought I'd put you guys on here and say, to my observation, you are going to have your customers are more likely to be in the provider community, and you're directly providing services to them and selling to them, and some to the health plan community, if you're involved in data mining, data management, a lot of the ancillary services around health plan functioning. And I'm sure a number of you are talking directly to the patient and trying to sell directly to the patient and make tools available directly to the patient. But very few of you, I would guess, are talking to my folks, my member companies. And so it's a problem. Because actually, I think in my community, you would find the greatest interest in the innovative solutions that can come out of the work you're all doing, but we are disintermediated by the structure of the healthcare system. And this will come up over and over again. Just to refresh you, if you're not paying close attention to trends in healthcare, I'll try to give you a 3-minute snapshot of the things that are on the minds of the big companies, the big employers in California and generally. First of all, this is kind of a stunning slide. This is the heading, if you can't read it, says, employers' confidence that healthcare benefits will be offered in their organization a decade from now. 10 years from now, will your company, Chevron, Safeway, whoever, be offering your employees good healthcare coverage? 23% think they will be 10 years from now. And look at the trend line on that picture. That's an unbelievable falling off. So to the extent you all assume, either because you're employed by one of these companies or you're selling to the marketplace which is supported by their dollars, this is not a sustainable expectation.
Are they assuming that the individual patient is going to be picking up the majority of that cost relative to the company having to pay for that?
Yeah, or the government. So there's a trend right now of shifting more cost to the patient, employee, and their family. But ultimately, you could imagine the exchanges or some direct single-payer model simply displacing the employer as the source of coverage. Yeah.
I was going to ask that in transition to the ruling today. The trend is directly correlated almost to the individual mandate exchanges and the fear that people are going to be dumping larger plans and dumping people on the exchange.
Yeah.
So from your perch, I would imagine you have a lot of insight to what people are actually looking for.
Yeah, well, we spent a lot of time talking about it. Most of these companies are sort of the good guys. They have rich benefits. They provide good coverage. They're affluent companies. But they are themselves, on this graph somewhere. I think most of the people on this graph who are in the 23% are companies like mine, because you expect, the Chevrons and Intels of the world will be around with good coverage for a long time. But the smaller employers just can't afford it, and they aren't expecting to be involved that long.
Just the timing, can you attribute any percentage of the declining curve of confidence towards future services having its peak in 2007 as being correlated with the 2008 market shock? I mean, it seems like that would be it.
And I think if you take that market shock coupled with healthcare costs going like this,
Better cross-cutting.
you just can't do it. Let me keep going through this, and we'll come back to more conversation. This was just my opening.
There will be 15 minutes at the end for questions.
Our biggest challenge is maintaining affordable coverage. So this is why they think they can't stay in the game. And I just circled the ones that may pertain to your business strategies, which is specialty drugs, appropriateness of care, new medical technologies, too many services. So the utilization of expensive technology, broadly construed, is half of the things they're worried about, the employers are worried about, driving up costs. So there's a sort of a dampening force coming from this conversation on the energy to introduce new products and technologies. And we'll of course talk more about that. On the public side, government sponsorship, not the employer sponsorship, you all seen that this is already, and we come back to the deficit reduction game in the next 6 months, how we're going to save money for the federal government to have a sustainable federal budget. This is what Obama has already said is on the table. Now last fall, he said $320 billion in cuts in 10 years. This number will be much bigger in reality. So we're talking about trying to save $1 trillion over 10 years out of healthcare. So again, the opportunity, the appetite for adopting new technologies, especially expensive technologies that are not cost offsetting, is really going to be diminished as these pressures continue to grow. If you haven't seen it, this is how out of whack we are in our spending with the rest of the world. This is the American per capita healthcare spending compared to everybody else. This is that we're not getting better health for it. You probably can't see in the back, but the United States is spending by far the most, but we're just in the middle of the pack on longevity and morbidity and so on. Undisciplined use of new technology, I'll say. These are the top bar is how often we do heart revascularization procedures compared to the rest of the world, about double anybody else. The second one is the MRI adoption rate in the United States, also much higher than most other countries except Japan. So again, the employers look at this stuff and say, gee, I've got employees in South Korea and France and Italy and Egypt, and they aren't using all this technology and they're fine. Why am I spending so much money for so much technology in this part of my workforce? And they don't have good answers. One more piece of this, which is this third-party payment. We all talk a little bit about that the consumer doesn't directly pay for things. Maybe that creates a distortion. This is just kind of interesting, the data originally from Safeway, you see at the bottom. Safeway went around just in the Bay Area, and they're self-insured, they're paying the bills for the health care that their employees use. So you're a Safeway, you're a checker or a manager at Safeway, and you go out and you say you're 50, it's time for your colonoscopy. What you do typically is you say, oh, where do I go? My doctor recommends this place around the corner, and I go there and I get my colonoscopy and I pay my copay, and I'm done. Safeway gets the bill for the rest, right? So the bill they get ranges from about $500 for a plain colonoscopy at a place over there on the far left of my picture, to $8,650 if you go to Pleasanton Surgery Center.
Wow.
So when the employee is simply, I don't know, they said go to Pleasanton Surgery Center, that's where I went. It was fine, and I got a good result. But my employer spent $8,000 for the $500 test. Because this lack of transparency this is just real objective empirical data happening to employees at the Safeway you go to today in San Francisco. So Safeway looks at this stuff and says, this is nuts. Why are we paying for any of these places over here? Why don't we somehow direct our employees to go to this part of the picture, unless there's some quality difference that's significant? Why wouldn't you tell people, please, go to the more affordable places? So this is, again, just sort of the context of where the employer is looking at their data and saying, what are we doing here? Lastly, lack of technology assessment. Yeah?
I have a question for you. You mentioned the data. From where is this data accumulated?
This is from the bills Safeway pays directly. They pay their own claims. So this is actually the check they are writing to these places.
So nationwide, are the averages that are pretty much predictable factors that can be?
Yeah, I would say everybody who does research in this space would say there's an 8-fold variation for almost anything you identify. In fact, I can show you the data for total hip replacement and knee replacement in California. The range is from 15,000 to 110,000.
Where is it that accessible?
Oh, it's not. It takes, Safeway has to
Yeah, Safeway, but
get the
national
data and
average,
do their
yeah.
own data mining to get the answer. There's no publicly available data like this. So it's a huge issue for big employers. And actually, if you're looking for business opportunities, this sort of data mining and transparency, there are a number of startups. Castlight, many of you know, is a local company that just got a big infusion of cash. Castlight is doing a lot of this kind of work for their employers here. Yeah.
So how are the health plans tracking that information? How are they playing the?
It's a really complicated business question. The health plans are negotiating prices between, say, Anthem or Blue Shield or Aetna, is negotiating with every one of these for the best price they can get, which is a market forces business dynamic. And they consider that proprietary. Each of them thinks they got the best deal. They don't want the other guy to know what deal they got. So there's this, it's a very complicated, I think it's a distraction for tonight, but the underlying economics here are really ugly.
Just
It seems fairly obvious to people in the medical and psychological community that prevention and health promotion is the best way to save money. Why is it so difficult to get the system behind that? When everyone who's in a position to recommend it and understands what's going on says, we need prevention, we need health promotion, we need lifestyle modification.
I would say that all the companies I showed you earlier are very serious about that, and they do a lot of work around identifying health risks and health needs and helping people get tracked into stop smoking programs and obesity programs and all that stuff. At the same time, they're paying these enormous bills. The money is flowing out the door. So they're in this, on one hand they believe in it and they're investing in it and they're doing pedometers and all kinds of things to get people into self-care and self-management. So there is a business there. I'm glad to hear about the company starting the wellness programming here. That's a good opportunity, but the CFO at these companies is writing checks in the billions of dollars for this stuff, and both are going on at once. Let me keep going through this and get to the goods for this. So this is just a New York Times editorial a few months ago. This is about proton beam treatment, and the headline is the main thing I wanted you all to be paying attention to. There's not an expectation anymore that new, expensive, snazzy technology is necessarily beneficial. And in particular, as this series of articles points out, they tend to be very beneficial for a small number of patients, but then applied to thousands and thousands of patients who may not get a net benefit. So the appropriateness of patient selection and treatment has become a really big deal. So my organization, Pacific Business Group on Health, we have a vision. So I'll share that with you, which is transparency about quality, cost, and outcomes, kind of things we just talked about, where both consumers are motivated to look for, like we saw in the Safeway drawing, the more cost-effective providers, and providers, physicians in particular, are incentivized to offer better quality, more affordable care. That's what we try to do. The kinds of things the employers I work with are talking about now Cost is going up, quality of care is variable and not transparent. Those two are not related to each other. What they pay has nothing to do with the quality of what they get as an employer on behalf of the employee. A variety of tools that have been around for years, those of you who work in healthcare are familiar with these acronyms, aren't having much impact, even though we've all worked hard to do this stuff. Expecting that the health insurance companies, the health plans will fix all these problems, which is where most employers were for the last 20 years, they don't believe that anymore. They're very skeptical about the health plans as partners in making a difference in quality or cost. Managed care was kind of the aspiration of the 90s. That's very little interest left by the large employers in managed care. A lot of frustration, frankly, with the delivery systems and the health plans of not trying very hard anymore. They are really kind of complacent. They've learned how to maximize their income in the current model, and they're not very enthusiastic about disrupting the current model. And they're not seeking efficiencies or improving quality as aggressively as we think they should. And again, you look at the companies on my list, they wake up every single morning desperate to innovate and improve and compete. And they don't see that same energy level coming from the healthcare system. Yeah.
Do you see many companies moving to a plan design like C-chain? C-chain, when the consumer takes the assessment or whatever wellness activities, then suddenly deductible goes down. And I'm wondering if they are finding that kind of plan design is more effective to change this dynamics.
So if you can, everybody hear, the question was whether it's some companies which are moving toward a much more consumerism model, where consumers have more skin in the game. And there's a lot of emphasis on people making wise choices, if that's being effective. And I think the answer right now is so-so. About 10% of people are in those kind of plans right now. And they are costing less, and they're using less health care, but they are actually skipping a fair amount of needed health care. So we're waiting, there's maybe a little balloon of additional care that's going to come down the road. So I think right now most companies are still going down that model, but cautiously, I would say. Cost savings innovation, which is really the theme of tonight, we're not seeing a lot of it. We're not seeing a lot of energy to adopt technologies and solutions people like you might come up with, which save money and address those earlier things I talked about. Health reform, despite our agreeing with Prannoy's opening that it's a good day and things are going in the right direction with the reform law, it isn't going to save money. It's not going to bend the curve. And that's a really profound concern by the employers. And then consolidation. Market consolidation is a huge issue for us. That is large insurance companies and large hospital and delivery systems merging into very large concentrations of market power in a community and basically setting prices and creating monopolies in communities. That's happening a lot in California, and it's a concern.
I think to that last point, it's not just consolidators of payers and payers, but payers crossing the line, playing a different role as player/provider in some places. And how much do you think that's going to be a driver in terms of how the provider space has changed when the payers tightly integrated? They're not all fully staffed models, of course, like the Kaisers are, but certainly there's more skin in the game from the payer when they're a provider as well.
Yeah, we're definitely worried about those trends. So the trends, again, if you couldn't hear it, is different actors are buying each other. And all over the country we're seeing hospitals buying doctors, health plans buying hospitals, with dialysis company buying a medical group. So it's a really interesting time, which is good, but very uncertain and makes people queasy because everyone's just chasing money. And that's the way we've created our healthcare system is very much driven by relatively short-term profit taking, and it's very disquieting if you're concerned about, if you're a large company, you've got a workforce of people who are 35 and you want to still employ them when they're 55, you're not that interested in this, moving the pawn pieces around the table.
Have you seen much activity at the DOJ regarding the mergers and acquisitions of some of these large systems in terms of antitrust and so forth? Are they becoming, I've seen some activity in Chicago where they've been quite active, and also in Illinois. However, I haven't really seen that much going on here in California.
Yeah, they are quietly giving it more attention than they were before. I think they love this concern. They have now begun to appreciate it. So yes, I think there'll be more of that. So what we're doing in our organization is really 4 strategies. Consumer engagement, so people are choosing the right care providers and treatments and technologies. Payment change, so we're incentivizing providers to choose the right services and technologies. Really getting our hands dirty with redesign of the care system to disrupt it, because we think the current models are not working terribly well. And then looking at the policy environment for the national healthcare reform, state legislation, antitrust issues, and saying what can we do to create an ecosystem which creates a more robust competitive marketplace where innovation can be supported. So these are examples of the kinds of things we do in each of those 4 categories, and you can eyeball them yourselves. You can see in the back a lot of work on transparency, both quality and cost. a lot of work around this shopping model, consumer choice models. How do we give people information and incentives to choose the more cost-effective services? Tools, we do a fair amount of tool development in terms of consumer decision support. I know some of you work in that space. We try to move payment toward global payments for value instead of fee-for-service episodic individual payments. And I'll talk in a minute about the redesigning care work. So I want to give you a few things I think large employers think about when they look at new technology adoption and innovation. First of all, what's valuable is that which produces better outcomes or is cheaper and gets the same outcomes. It's a really simple rule of thumb that I think most purchasers bring to conversations with folks like you. Secondly, they almost will never pay for new technology. You can't go into the benefits department at Chevron or Intel or Cisco and say, I've got a great new gadget that'll really help your employees, why don't you buy it or pay for it? They won't. Very, very rare. So instead, they're going to try to find a way to get their health plan to cover it or to have a consumer-directed benefit design which will incent people to use it. But it's an indirect model, at least as far as our community goes. What they want to pay for is say to the physicians and the clinics and the hospitals, I want you to get better outcomes. Now, if you need to go buy that new asthma gadget from an inventor of a new asthma gadget, that'll produce a better outcome, go do it. I will incent you to achieve a better outcome, but I won't incent you to buy the gadget. So that's the paradigm, at least, of the employers. Measuring and monitoring appropriateness is a big deal. So if we introduce a new technology, a protein beam therapy, it might be great for a tiny number of people, but then we've seen over and over again it gets applied to 100 times as many people who aren't really the primary beneficiaries, who could do just as well with a less expensive technology. So show me that what you're doing will be used appropriately and not drive up my total cost. Comparative effectiveness research, there's this new institute, PCORI, a federal institute, to study what works in healthcare. It has been prohibited by Congress from studying what's cost effective. We don't think that's the right course, and we would support consumer effectiveness models which do include, comparative effectiveness that does include cost. Aligning payment is a big thing. And then the last thing I mentioned here is total cost of care. Meaning there's a lot of interest in this, which is saying I don't want to look at that hospitalization or that doctor visit or that month of rehab care. I want to look at a year or 3 years of care. What are the whole episode of that heart attack or that knee replacement or that asthma 5-year-old episode? What did that cost as a whole? And then let's look at the components that were put together to optimize the cost over time. Yeah.
Can you talk a little bit more about the second one, don't pay direct technology for outcomes?
Yeah.
So especially in this region of the country, when you have innovative technologies, there's a business plan and a promise of an outcome, but not a whole lot of proof over 3 years of what the actual equivalent in the industry. So how do you get that case across to?
Well, my companies are not typically early adopters. They're going to wait to see some of that evidence from other trials and pilots and prototypes. So I think gathering data that would convince them that this is true as you do those early experiments is really important. There are some exceptions to all those, not my generalizations, but in general that's how they're going to come at it.
My question is to your last point about the total cost of care. That was actually done already back in the 80s with DRGs, the formation of DRGs, diagnosis-related groups, where you're looking at a whole episode of care, and looking at the individual components of that care along the way. And DRGs, I believe, are still around, but they're not really being used to the full extent of looking at a whole episode of care or the time frame going from beginning of the heart attack, maybe, or the heart condition. You know, that's unknown. Maybe they'll take it back to when the person started eating 20 years ago and really looking at that whole episode, which is a more appropriate, comparison. But I guess, are you suggesting that we're going to start seeing this DRG-like focus again?
Yeah, I was just reading a paper this morning that's talking about how to clump DRGs together and make a meta-DRG or mega-DRG. So episodes of care is the term of art right now, and bundled payments. And both of those imply a longer time frame. A DRG is typically a hospitalization.
Right.
But if you take the 30 days before the hospitalization and the 90 days after the hospitalization and call that a single payment, that's an episode. That would be a big construct. So that's where that's going.
And is this related to the ACO model? And
Yeah.
Okay.
Yeah. So let me go give you 4 quick examples of what our members are looking for from innovation, and especially from technology innovation. First is something we've been working on called the intensive outpatient care model. Second is innovation in colorectal screening. third are devices, and fourth is diagnostic testing. So the first one, this is a primary care case management model. Basically identify the 10% or so really sick, really expensive patients who keep falling through the cracks, have terrible problems, often behavioral health comorbidities, multiple chronic illness, chew up money, go on years and years in and out of the emergency room. If you read the Atul Gawande piece about a year and a half ago on hotspotting, that's this population in Camden, New Jersey. So what Boeing did in Seattle, Boeing as an employer said, we're sick and tired of this, we're spending millions of dollars on these people, they're not getting better, we're writing all these checks, this is crazy. We're just going to go in there and meet with the big medical groups in Seattle, and we're going to hire nurses for them. We're going to train the nurses ourselves, we Boeing. We're going to install those nurses in these clinics, and we're just going to manage the heck out of these really sick people. And we're going to run an algorithm against a big data set to identify who is likely to be benefited by this model of care. So they married up a case-finding algorithm of identifying these candidate patients with a primary care assessment strategy of who can deliver this kind of care, inserted a trained nurse into the group, and then tracked them. They developed a whole feedback system, so there are dashboards giving the doctors and nurses really tight daily feedback on how these patients are doing, where they're falling through the cracks. They saved 20% on cost for this population, reduced admissions by 28%, increased their mental health functioning scores by 16%. Patients were satisfied, felt like they had 18% better access to care when they needed it, and their 56% decline in lost work time from this population. This is a tiny number of people, there's 700 people who are really sick, really expensive. These are million-dollar patients. And if you get on top of this group, you're really making a difference in the cost of health care, and you're improving lives for 700 people.
So these are the individuals who work for Boeing?
Yeah, and their family members.
And their family members.
Yeah.
So how do you broach the subject that they or their loved ones are frequent flyers and
well, actually, typically you don't. So the way this was done is by their current primary care doctor said, gee, Mrs. Smith, you know, we have this other program across the street, which is really great. I know you've been really frustrated. You've been in the emergency room 3 times this year. I know you're having trouble staying on your medicines. I know you can't get out of bed in the morning because you're really feeling lousy. I think this group across the street can really help you out. You can come back and see me whenever you want, but why don't you give this a try? So that physician referral was really critical, and not breaking the bond of trust that those people often have with their providers. So I just want to give you that example. We then did the same model in Humboldt County, California, and in Orange County, California, with different employers. PGE here, CalPERS, where their employees were brought into this kind of program. Boeing remained very involved as a guidance. We then sent this as a proposal to Medicare and said, why don't we do this for all California Medicare population, which is really where a lot of this chronic care falling through the cracks is. And we just a couple weeks ago got a $19 million contract for Medicare to do the same thing statewide in California, and actually probably Arizona as well. So this is an example of employers, Boeing in this case, stepping out, developing a model, really getting their hands dirty with the care model, innovating. And there was a lot of technology innovation here. There were care management models, measures, feedback, evaluation systems, the care delivery model itself. That was not nuts and bolts hardware, but it was soft process technology that made a huge difference in the lives of these people and in the program, and has multiplied out. So that's a soft innovation. Employers love that stuff. Second example, colorectal cancer. This is more nuts and bolts. Today, this is Canadian dollars, but you can guess your own numbers. You saw the colonoscopy data earlier. In whatever this time frame was, 2000, I don't know, it says on the bottom below, before 2010, colorectal diagnostic screening was 857 Canadian dollars on this slide. A new test called the FIT test is $19 Canadian. Has to be done more often. It's much less invasive, much easier to do. It's self-administered. Has been very, very slow to get adopted. So there's a program actually at Stanford, a think tank at Stanford, saying, how do we get adoption of this $19 technology to replace this $1,000 technology? Which no one wants to do a colonoscopy. One of the problems with it, you see on this slide, is that 40% of the people don't want to do it. They won't get their colorectal screen, including my mother, by the way. She just won't go through the procedure, never has. So that's a technology, it's an established technology, it works fairly well, but we can't get people to do it. Now we've got a much cheaper technology, which is much easier to self-administer. How do we get people to do it? So what this institute is doing is looking at the entire, as you see here, the workflow, and both the cultural, psychological, business, and technical issues of implementation, and saying, how do we get this much cheaper technology widely adopted. So that's very attractive to employers. They'd love to sign up for a program of cheaper technology, wider adoption, save more lives, detect more cancers, save money too. Good thing. Third example, implant selection. This is trend data on the cost of orthopedic surgery, hip replacements and knee replacements from 1992-ish. And you see this is what doctors get paid to do the surgery, flat line. This is what hospitals take in revenue, flat line, 20-year flat line. Where's the steep curve? New technology. Huge increase in the implant list price for the coated hip and the selling price for the hip. Have we had a benefit to society by the increased cost of the technology? One of the interesting sort of ironies of this is that the new models of the implants are actually, some of them are great, some of them are actually dangerous and bad, and you've probably seen headlines about them being pulled out of patients because the new technology was brought in too fast and wasn't evaluated well. Now, interestingly, in Sweden, where they have a national registry, and they've been tracking this very closely, they use about 4 products and have since the mid-90s. And their revision rate, the rate at which they take out bad hip implants, is about 1/3 of what ours is. Ours is about 8% of people have their hips removed because of failure. In Sweden, it's about 3%. They're using an older, established, basically generic technology which works fine, a cemented technology. We went down a technology development path that was ambitious, uncemented, new titanium products, very expensive, a lot of marketing behind it. We have, for example, the pink hip, which was for women, which had no functional advantage, but it was a very good marketing strategy. And so we ended up with headlines like this, that the new technology for artificial hips and knees is not better. So what we've been doing as employers is building a registry in California, the California Joint Replacement Registry, to collect data from all the implants done in California, give the data back to the surgeons and hospitals to show them what is happening with these devices, and that they will be more careful about the selection of devices and how they match to patients. Because like Sweden and New Zealand and Australia and Norway, England, we will finally have a registry to keep track of these products, detect problems early, and address them quickly instead of waiting 5 years longer than other countries do to correct problems in these models. So the kinds of things that the California Joint Replacement Registry is worried about or interested in is helping people improve which patients get which devices fit to which patients, managing the care process better, and so on. I'm going to keep going through to get to the end, then we'll take a few minutes for discussion because Laura's doing her job. Same thing for cardiac interventions. These are stents inside your coronary arteries. Overuse stents in stable patients, very widespread, probably 1/3 to 1/2 are unnecessary, inappropriate. The American College of Cardiology, the cardiologists themselves, finally got together and made a list of what is appropriate uses for stents. And in doing their list, they actually wrote a little statement to people like me that says, services performed for appropriate indications should receive reimbursement. In contrast, services performed for inappropriate indications should not be paid for. This is fantastic. The doctors actually said, don't pay us to do the wrong, unnecessary stuff. So now the question is, how do we implement this in the real world? And I would love for some of you to solve this problem, because what we don't have is a methodology for observing conformity or non-conformity to these guidelines, and then setting payment and recognition and consumer incentives. So if I need a stent, I want to go to the people who use this technology appropriately, not to the ones who might be like those colonoscopies on the far right side of the chart. Last example is pure consumerism, pure consumer play. You may have seen this about a month ago. 9 medical societies, the kidney doctors and the family doctors, got together and put together, each of them, a list of 5 things in their specialty that don't need to be done, or not done as often. And they, again, like my previous example, they basically said, fellow physicians, don't do these 5 things. Even though you could and have been, don't do them. But their strategy has been to communicate to the public, to patients, to the you, choose wisely. When you go to the doctor for a regular physical, don't get an EKG. If they suggest an EKG, say, no, I don't need it, I don't want it. I know you'll make $50 more by doing it, but I don't need that. Because Safeway is going to have to pay for it if you do it. And it doesn't do me any good. So there's a list of these kinds of things. Imaging studies in patients with low back pain is not indicated. It's not valuable. So now Consumer Reports, Consumers Union, is developing all the collateral material for consumers, and employers are going to start pushing this out to their workforce. AARP just published a special issue of their magazine with this stuff in it. So the question is, how do you get consumers and doctors to talk to each other about what's appropriate? And what technology, these are all technologies, which technologies should you as a consumer, as a patient, be seeking or avoiding? Last thing I'll just mention is technology assessment. This is a group of employers in New England who got together and formed their own council to look at each new technology and decide whether to pay for it together. So there's a lot more activism on the part of employers now around this set of issues. Very last thing is the policy agenda. I did mention policy work, and this is the place we might want to talk about health IT. We do a lot of work in Washington on national health policy, on all these things here, all of which are somehow meant to address appropriate use of new technology. So this is just sort of signaling to you that these employers I started talking about, this is what they are worried about. How do we create an environment where new technologies that are valuable and improve health outcomes get adopted, and those that add to cost and don't improve outcomes don't get adopted? And how do we do that? These are all capitalists. They want to do that in the marketplace. They don't want the government to say, thou shall not use this technology. They want to create an environment that rewards appropriate, effective care and doesn't reward unnecessary, expensive care. So that's what we're doing. So my last slide is messages to you guys. Implications for developers. First of all, understand what pressures your providers, if they are your market, are under. They are under pressure to improve efficiency. They're under pressure to document outcomes of what they're doing. They're under pressure to increase coordination, including across settings and across time. And they're under pressure to be accountable for what's appropriate in the care they provide. If you're selling to consumers, understand the pressures on them. They are feeling increasing cost sharing pressure. If they work for Safeway or Intel or Cisco, they are paying more of the bill themselves. So they're more cost sensitive than they were 5 years ago. They want and they're getting more information on prices and quality. Companies like Castlight are being supported to deliver information, to push information to the consumer. And most of them are facing more, frankly, responsibility, either good or bad, for the decisions they make. There is a lot of interest in patient engagement and autonomy, treating all of us as adults capable of making decisions about our health care and which treatments and services we're going to use. So that's an opportunity, I think, for many of you who are going to be selling directly to the public. And then lastly, as I mentioned before, innovate. Innovate is good. New care models, new care processes is good, but you're going to get a wariness or a skepticism from at least the large employers that a new gadget is necessarily good, unless it fits into a care process which seems to make sense and ultimately lead to more efficiencies. I think I'm done. Thank you all. 5 minutes, all right.
So, in your crystal ball, since you look at large employers, and these are firms that can afford just about anything you want in general, do they have a motivation? There's a squeeze.
There we go. Good. Sorry about that. How's that? Is that better? Okay. Part of the thing, you work with large employers, and I've actually worked with some of those large employers as a marketing consultant. But the issue is that it would seem when I've been sitting in the executive suites, they're trying to find ways to cut costs. It would seem to me that a single payer model actually benefits large employers. Have they figured that out yet?
I think they understand that. It goes so deeply against their culture that they aren't quite there. But I have, in our private closed-door meetings, the last 2 years, I would say they see that as a 10-year roadmap that is plausible. It's not their desired outcome. They would rather have a competitive market. They think that works better. That's what they believe. But they are no longer, I think 10 years ago, they thought single payer was unacceptable. Now they think it may be the right answer.
I like that slide, the Safeway slide of the cost of, what was it, colonoscopy? And I'm thinking, since most of those employees are paying a copay, if the company said to them, if you get this colonoscopy at a price below X, we'll pay part of your copay. If you get it below Y, we'll pay all of it. And if you get it below Z, we'll pay all of it and give you a bonus. And that was combined with a law like the law for gas stations that have to post their prices, thank you, that these places have to post their prices, which of course they'll scream about, but it's doable. I mean, if the Chief Justice of the Supreme Court can say that mandated insurance is legal, then we can certainly post prices. Do you think that combination is the kind of thing that would reduce the costs and give the competitiveness of the marketplace meaningfulness when the consumer actually cares about the price?
you have an opportunity at Safeway, because that's what they did. They went to this line, and they went to $1,500, which is here, and they drew a line. And they said, we will pay, anywhere you want to go, we'll pay the first $1,500. If you want to go here, you can go. You're going to pay $2,200 out of your pocket if you go there. So publishing the prices was critical to that strategy, so that people would know before they made the decision that that's the implication. Safeway strategy has actually been to take what you described.
So Safeway had to publish those prices.
Yeah, that's what they hired Castlight to do, essentially.
And it took probably quite a bit of effort for Safeway to put that together, and not just for one procedure.
Right, they've expanded that. They have gone after the commodity services like labs, imaging, X-ray, colonoscopy, and that's where they've done a reference pricing there. CalPERS, the state employee program, did the flip of that. They went after the very high-cost services like orthopedic surgery, spine surgery, and they set a reference price, in this case of $30,000 for total hip and total knee, and said if you want to go to the $80,000 hospital, you can, but you're going to pay $50,000. Now obviously that only works where the consumer is properly informed in advance.
Exactly,
And
that's the issue of having the prices posted like the gas station.
Right. Yeah.
Did Safeway go the next step and extrapolate that data to look at outcomes based on each of those individual places, and then also take into account how many biopsies were done for which polyps and things like that?
I don't think they did, at least not adequately. One of the failures of this model is that it makes an assumption that today we have no discrimination based on quality among them, so it's not any worse to draw this price line. Personally, I think they should associate a quality standard with the introduction of a price threshold, because otherwise they'll be accused, rightly or wrongly, of skimping, and if somebody goes to one of these places because it was cheaper and has a bad outcome, the company will be blamed for having directed them to the lower priced place. So I think it should be a corollary of this model to capture quality data, and I don't think they've done it adequately.
So he's next.
I'm sorry.
Sorry. So a quick question. Using this slide reference to another slide you have about how hospital or doctors are being paid for the total hip replacement. You're saying over a 20 years period their payment has been very stable, and the cost driving that up is actually technology. So have they done a study on this particular slide? Is the cost differences because they use different technology, or is actually the labor cost for those is varies?
Well, actually, that's hard to see, I'm sure, in the back, but this orange color is room and supplies, which is not the technology input to this. These people are charging hotel fees, basically. So on this particular example. But your point's well taken. One needs to drill down on any of these and make that assessment.
Monte Carlo hotel fees.
I just wanted to add more really close on that also. Then it seems like
Pointed away from the speaker.
I'll point it away from the speakers. If you look on the list, number 5 is located in Stockton, California, which is notorious today for having been both a county seat and a city to file bankruptcy. And it seems like there may be some value also in considering what behavior changes in the consumer base due to the net operations of these facilities. And I guess I'm really asking a question about how when you are a market maker, do you deal with the issue of sustainability? Because the pricing models that are being used there may not be appropriate on scale. And that was sort of a...
Yeah, I think this is a blunt instrument and doesn't address a lot of the issues you all can raise about the weaknesses and risks of this approach. I want to share with you partly to say what the employer's fed-upness is starting to look like, that they're going to start setting these I can't take it anymore levels, and just saying affordable means $1,500 for this particular service. One of the things in terms of reputational credibility, when CalPERS did their total knee and total hip strategy, they made sure they picked a number that included Cedars-Sinai, UCSF, and Stanford. So they didn't want anyone to say, well, Stanford, I can't go to Stanford anymore. No, you can. It's under the line. So they bumped the line up to cover the reputational issue.
These are.
Oh, I'm sorry. Go ahead.
How do your employers feel about the favorable tax treatment for benefits?
No, we're about to talk about it. We haven't yet. I don't think it's going to be a big issue for them. That is, a change in the tax exclusion would be considered palatable. But we haven't. They don't think it's a cost saver. That is, there's some argument that changes in the tax treatment would lead to a downward pressure on prices as a whole. And I think instead it's really being looked at as a revenue generator for the government. And until that's clarified a little bit, I think the employers won't know where they come out on it.
Are we, this example is Safeway, but there are lots of smaller organizations out there that are not self-funded. They're purchasing fully loaded or fully insured plans through payers. Have you seen any of these types of programs that the payers are actually doing, wherein they are combining both quality and cost thresholds?
Yeah.
And which ones are they?
Well, the term of art in this is called tiered networks, and essentially they're trying to identify groups of physicians and hospitals who do deliver higher quality outcomes with less expense incurred. And then they give them a gold star. And then the trick is to either have a narrow network where you kick out the providers who don't meet that criterion, or more often now, you say to the employee, you know, we're going to waive your copay if you go to the good providers, and we're going to make you pay a lot more if you go to the bad providers. So that's a tiered network, like a formulary only for providers instead of for drugs. The question is, there probably isn't, so United Healthcare has done that, Aetna has done that, for example, Blue Shield has done that. The problem is it's not convincing that the providers they're choosing are really superior because of the quality of the data they're using to make those judgments. So one could be suspicious that they really fall back on cost saving.
Are they using claim data versus actual clinical data?
Yeah, they're using claims data.
Okay, we have to kind of cut it short here. So if you have additional questions for him, I'm sure he'll stick around.
Right.
So let's get a big round of applause. Okay, at this point we're going to take a short break. And so what are we going to say, 10 minutes? Me back.
And I spent the first part of my career in academic research, and I had an NIH-funded research lab at Oregon Health Sciences University. And I left after about 6 years. I started getting frustrated with academic research for a variety of reasons. And I confess one of them was because I hated writing grants so much. And I was actually pretty successful at it, but it was just like pulling teeth. So it's one of life's little ironies that now I make my living doing it. And actually you can learn to sort of love it. So let's see, advance this way. My sense when, so I'm relatively new to interacting with the business community, but the sense I get from people I talk to is that many people are reluctant to apply for grants from federal agencies because either they believe the government doesn't like to fund small businesses, or they think it's just too hard to write a grant. It's just, you know, there's something about it that's impossible. So I'd like to dispel both of those notions. First, the Small Business Innovation Research Program, SBIR program, is a federally mandated program since 1982. It has been required that federal agencies with extramural budgets above $100 million must administer these programs and give grants amounting to an annual set-aside of 2.6% of their institute budgets. So 2.6% of each NIH institute's budget is set aside for these grants, which means they're actually easier to get than standard research grants that academic professors typically apply for, and which have no set-asides. So you may have heard about the terrible pay lines at NIH, and indeed for regular research grants they are pretty bad, as low as 10th percentile. You have to be above the 10th percentile to get paid, but for SBIRs it's actually better than that. It's more like the 25th percentile. And with a second submission it gets up to more like 50% of the applications get paid. So what kind of money can you get through this mechanism? SBIR grants have, you apply for either a phase 1 or a phase 2. Phase 1 is feasibility and design, for example, developing a prototype for some software platform and then doing a little preliminary usability testing on it. And that's a relatively small award, $150K. But then if your phase 1 project goes well, you can apply for a phase 2, which is much more substantial. That's $1 million, and that's to further develop your product, refine it further, add bells and whistles, do clinical testing, or what have you. If you're wondering whether you're eligible for an SBIR, here are the guidelines. And now here's the hitch with SBIRs or any kind of federal grants, is that it's not fast money by any means. So if, for example, you were to submit an SBIR grant for the next deadline, August 5th, your grant would go to study section and be reviewed by your supposed peers in October or November, and then you wouldn't you'd hear a funding decision in a month or so after that, but then if the funding decision is positive, you wouldn't actually even get the money until April 2013. So that's 9 months between time of submission and time of payment, all going ideally, that is, you get paid on your first submission. There are 3 deadlines a year, April 5th, August 5th, December 5th, so if by chance you don't get paid on the first round, you can get right back in, get back on the horse and try again. And you can also submit multiple grants that are sort of clones of one another, technology to treat, let's see, mHealth tool to treat smoking, mHealth tool to treat obesity. You can send those both in simultaneously. This one? Oh, these are the requirements to be eligible.
To submit a grant.
To submit a grant, yeah.
So is the only difference between SBIR and STTR? In the STTR, you have a university.
Right. So with the STTR is Small Business Technology Transfer Program, and that requires an academic partner at a certain percentage. I think it's 30% for the academic partner. And again, the idea with those is still to be moving work from the lab into the marketplace.
Can you speak to the last item, the IP security?
Yeah, that's my.
I was afraid you were going to ask me some hard business questions. I can't. That is something that you would have to delve into the small print for yourself. There is IP protection. I know for sure, else people wouldn't apply for these grants. But the details, if you want, I'll look them up and get back to you. Okay, so the other reason people don't apply for NIH grants is they think there's something like mysterious about it, that you can only get one if you know the right people, or the secret handshake, or the secret password, and that, you know, there's a lot of politics involved and only certain special people get funded. There is a certain amount of politics involved, but in fact, it's not really that mysterious. There are 3 basic rules for writing a fundable NIH grant. First of all, you have to have good science. That would be a logical plan of experiments, or in your case, a logical plan for product development that produces a useful return for the taxpayer dollar. I assume you all feel that you have that part in place. There has to be truth in advertising, i.e. you don't want to be overselling yourself or claiming that your product reduces some health problem by 25% if you don't actually have controlled trial data showing that. And then you have to present your work in a clear and interesting fashion, and that actually, number 2, is the hardest part for most people. Yeah?
What's the qualification of those reviewers? Like, who are those people who review?
It is extremely variable. So your grant gets sent to a studies section that ostensibly has expertise in your area, but particularly for SBIRs, it may be that there is nobody reviewing your grant who really knows that much about your topic. So when you write an NIH grant, you have to be selling to a assume you're selling to an audience that's intelligent but not necessarily expert in your area. And there are things you can do about directing your review. That's sort of part of the insider part of the thing. Yeah?
Yeah, normally, although we call it NIH grant, for SBIR, we have to NIMH for mental health.
Uh-huh.
National health.
You have to pick the agency.
And then you have to topic they are interested in. And then
Not necessarily.
That's the way I kind of hard.
I'll be addressing that. Okay. So just briefly, there are a number of agencies that have small business grant programs. DoD actually has the largest SBIR budget of all the agencies. They have 5 times the NIH SBIR budget, and if by any chance your work is applicable to, for example, post-traumatic stress disorder, you might think about applying to them. That would also include any stress-related health conditions such as depression, addiction, obesity, etc. They could have solicitations that would be good for you. NSF does a few health technology-related grants, not a lot. USDA also a few. Private foundations, urban legend has it that small businesses can get funded by private foundations. In my much trolling through foundation websites, checking this out, my impression is that most foundations do not give grants to for-profit institutions, or what do you call yourself, for-profit companies, directly at least, but they will give grants to academic researchers who might be working in partnership with you. And so it's worth, if you have the targeted disease area, to check out the nonprofits that are appropriate for the health area. NIH, so to address your question, NIH is composed of 27 institutes and centers, each of which is responsible for a certain group of diseases. You can find out the missions of each institute by looking on this website. The missions frequently overlap, so for example, Alzheimer's disease is covered by the National Institute on Aging, National Institute on Neurological Disorders and Stroke, National Institutes of Mental Health. So if you have a choice of institutes that are relevant to your project, your next thing to consider is what is the institute pay line. So the percent of grants that get paid in any round by each institute differs from institute to institute depending on how they've handled their budget. For example, the Aging Institute some years ago made a decision to sink a lot of money into Alzheimer's centers, big center grants to which then they were committed, so that their budget for regular research grants then began to dwindle. So now their pay line is not good. So that's one criteria on which you would want to pick an institute if you have options. Another would be if you happen to know a program director or at an institute who happens to be particularly interested in the topic you're studying. And you can find out all those things through various ways that I will reveal to you. Oops, that didn't work out well. So there are various websites where you can look up funding opportunities, searchable websites, and there's a list of them.
How do we get a list of that?
Pardon me?
We'll put that slide deck on the meetup site, so in a few days.
Yeah, if you guys,
both slides.
If you want to email me for anything, you'll have my address at the end. So I'm going to focus on NIH because that's the major go-to federal institute for health technology and health in general. So there, you can either submit a grant through an unsolicited, as they call it, or investigator initiative route, where you pick the topic, just completely, you decide yourself what your topic's going to be, or you can reply in response to a specific funding announcement. These are areas in which some person or group of people at NIH has decided we need to do more research on this topic. And the decision that they ought to stimulate research in a particular area can be motivated by, for example, a group of powerful, respected extramural scientists gets together and calls the institute director and says, we need more research money for the kind of research we're doing, and the institute director goes along with it. Or program directors may themselves see that there are certain areas that are being underserved and that need, a shot in the arm. And then sometimes then fads will happen, and there's a fad right now in telemedicine. So one institute will get interested in, for example, virtual reality technology for obesity, and then that would be heart, lung, and blood. And then Mental Health Institute goes, oh, we should do something with virtual reality too. And so then their program directors develop an announcement. There are 2 types, program announcements, or PAs. These do not have funds set aside, but they are released to indicate that a particular institute or group of institutes has a special interest in the topic. And then there are requests for applications, or RFAs, in which there are specific dollar amounts set aside to pay, a certain amount of grants for each round. And it's typically not a huge number, so these can be dicey to apply for. If your project is like the poster child for this particular RFA vision, then you have a better than average chance of getting funded by applying through an RFA. But if it's not, then you probably have a worse than average chance. And in these case of RFAs, the institutes or the program director running the RFA typically has a pretty clear vision of what kind of application they really want, which may be based on some workshop that was held that decided what the needs were in a particular topic area. So the relevant NIH grant mechanisms for you are the SBIR, the STTR, which I now discussed. There's the funding amounts for those. And then, contrary to popular belief, businesses can apply for regular research grants, the standard vanilla R01 grant. Sadly, there is still prejudice on the part of study section members who are mostly academics against businesses applying for these grants. So you're better off applying for R01s if you have a partner who is at an academic institution and who would then subcontract to you. So then I mentioned the funding solicitation opportunities. If you want to submit a grant, if you go through the funding opportunities, nothing really applies to you. Do not try to mold your research to fit something somebody at NIH wants if it doesn't really fit. Instead, just put in your project the way you envision it and submit through the NIH Omnibus SBIR, which is a solicitation that comes out every year that is for all comers. So the grants are expected to be investigator initiatives, that is, you come up with the ideas. And most of the NIH institutes participate in this, so then you also have the option of picking what institute or institutes to submit your grant to.
Excuse me?
Yeah.
Do these tend to be of a certain size, these kind of investigator-initiated grants?
Everybody wants the maximum amount of money they can get, which is $150K for a phase 1 and $1 million for a phase 2.
But I'm guessing that's not like the average that's granted, but where is it?
I think it's close to
really?
that,
Okay.
yeah. In fact, some people sometimes limit them. They describe more work than they can actually afford to do with that budget, and then they give that as a caveat at the end and say if the funds run out, the company will be willing to put in whatever is extra is necessary to make sure that the project comes to fruition. Okay, so where to look for NIH funding announcements is the NIH Guide for Contracts and Grants. It disturbs me that my titles are falling out of their squares, but whatever. So I plugged in, there's the website, I plugged in telemedicine, it generated a bunch of solicitations. The NIH Guide is not smart, so if you put in, I only pulled up a few for telemedicine. Then I plugged in mHealth, and I got different ones. So actually, I find it best to simply browse through the recent announcements, browse through everything, and see if anything strikes my fancy or seems appropriate. Then the NIH Reporter site, ooh, this thing is diabolical. Every grant that's funded by NIH is listed on this website. So that means you can go in there and find out what kind of things are different institutes funding lately, what projects that might be like yours have been funded lately and that maybe you shouldn't go in and try to reproduce. You Have your competitors been funded, and if so, for what? And which of the institutes fund projects like yours, and who are the relevant program people there who might be interested in your work, who you should then call? So here again, I plugged in telemedicine as the search term, and I think it gave me 19 listings, so I could only fit in this many. So for each grant, it tells you the grant, and I also specified SBIR, so these are just the SBIRs. There's the grant number, the project title, the principal investigator, who they work for, which institute funded them, how much money they got, and then you can, for each project, look up even more detail about when is their start and stop date, so you can know if, for example, their grant's running out soon, and who their program director is. So now you know that Nina Silverberg, who I happen to know at the Aging Institute, is interested in computerized assessment by remote examiner systems, and she might be interested in related things. Yeah?
Do you look for factors such as the number of employees or your revenue per year, things like that? Or do these factors influence their decisions?
They shouldn't. And in fact, in the regular basic research grants world, if you have too much money, that's usually seen as a bad thing, because then you don't really need any more money. I mean, what you need to show is that your company has either a good track record so far or a good chance of success in the future. But at no point do they actually ask you how much. They don't look at your budget. All they can look at is what other grants you have. That's the only information that's available to the reviewers. They can't look at your... No.
So if you were a subcontractor on somebody else's R01 grant, does that get you preferential treatment when they would look at you, or was it an advantage?
I'm sorry.
If you were a subcontractor on an R01 in an academic institution.
And then you went in with your own.
And then you went in with your own idea that was totally
yes,
separate. Yes,
I would say that would be positive.
That would be positive.
Yeah. Okay, so then I went through the NIH guide and I just pulled up funding announcements that are currently active that are in the health technology area, just so you could see the kinds of things that NIH is looking for right now through solicitations. And there was a little wave of these that started about a couple of years ago, where the NIH Institute started getting interested in telemedicine and health. And first it was one institute, and then the other Me Too's jumped on, and the wave is still going. So it's actually a good time to look for these specific solicitations.
So are these specific for SBIRs, or are these open to everyone?
Some of the, so our 43, 44, those are SBIRs. This one is an R01, that's an SBIR. Frequently, an institute will release an RFA on a certain topic, and they will do it, they'll have separate announcements for different mechanisms. So there will be an R43 announcement, an R01 announcement, an R21, so you have different routes you can go in. Yeah?
I'm sorry if I missed your response to this question, but I'm curious that what if your project or idea fits, let's say, under two of these solicitations?
Oh, then lucky you. Then you call the program directors in charge of each one. You see which one seems to like you better and be more excited by your ideas. You find out what their set aside is and how many grants they're planning to fund with that solicitation. You cannot, however, submit the same grant to the same solicitation. NIH has a very serious rule about do not submit the same thing under try again and through two doors. Although you can tweak it, and then there's just some more. And what time do we have today? Do I see signs?
10 minutes.
Yeah. 10 minutes, okay. So this is the NIH system for those of you who dare to enter. NIH is developed, the extramural program, which is the part of NIH that gives out grants, is divided up into different departments that have different jobs. So the institutes we know about. They're the ones who think about what are the big public health problems and ultimately give out the money, and they're the final decider about who gets paid. Center for Scientific Review is where the study sections are organized, and in fact, unbeknownst to many, CSR has probably far more power in the final funding decision for a grant than even the Institute, because those scientific review officers, NIH staff who run the study sections, they decide who to assign your grant to for review, and by assigning to either people they expect would be excited about your topic or who might not necessarily be so excited about your topic, they can regulate your score, within a wide window. Now, these are officers of the federal government and they have ethics and stuff, so they of course try not to do that kind of thing, but in fact, a lot of stuff happens sort of subconsciously at the application assignment to reviewers step. So your application goes in now electronically to the Division of Receipt and Referral, and they make big decisions about is it a neuroscience grant or is it a cardiology grant, and they send the grants to different sections at Center for Scientific Review, where the grants are then parceled out to the specific study section. Then your grant is reviewed typically by 2 to 4 or 5 reviewers who are the ones who weigh in primarily with comments, but they meet together with, say, 20 other reviewers who also have access to the whole pile of applications and who are free to pipe up at any point. So if you decide to submit a grant, figuring out how to direct it to an appropriate study section and make sure you have the most favorable climate for your review is a very key step. So then the study section scores, they're supposed to score strictly based on scientific merit. Of course, personal factors can come in there too. They give it the priority score, which then serves as a funding recommendation to the institute involved. The institutes then, they typically will pay the highest scoring grants, above the 10th percentile, the 20th percentile, or whatever their pay line is. But many of the institutes have some wiggle room with that, where they can either reach down to pay something that scores lower, or even eliminate or not pay something that has a higher score. And those decisions are made together with the Institute's advisory council, which is a group of the great eminences of the field who gather together with the Institute to pontificate and think about these things. And so then that's where the final decision is made. So your NIH contact people at the Center for Scientific Review is the scientific review officer, the person who runs the study section. And you're free to contact that person before your grant actually gets assigned to ask whether they think their study section is appropriate for your grant. And then it's a good idea, once you've picked a study section, to include a cover letter with the application directing it to the study section you like. And then your person at the Institute, the ultimate decider about your funding, is the program director, and you can call them either before or after the review to ask their advice on what study section to send the grant to, whether they think that your application is appropriate for their institute. The program directors actually attend the reviews often, and so if they like you, they can call you from the site of the review and give you early feedback on what the discussion was. But they're not supposed to actually intervene with the review.
During the review process, might they contact you and ask for clarification, or is that allowed?
No. Once your thing is submitted through the electronic submission system, that's the end of that. You can, if you get a paper published, accepted for publication after you send in your application, you're allowed to send them that information, but that's it. The only case in which you can argue sort of with the review is most of the institutes have some amount of discretionary funds, so they'll pay down to a certain pay line, but then they have some extra money to pay grants that fall into sort of a gray zone. And then the program directors help decide which of those to pay, and then the program director might call you and say, oh, the study section had questions about this, that, and the other. Can you answer that? Have you published anything more? Do you have any new data? So we already talked about this. And then, yeah, call your program director. So some people are like terrified of NIH staff, but they're like people like me, you know, they're just like, most of them are like really nice, nicer than the average academic scientist, I'd say, in terms of being warmer and more of a people person. So give them a call to see if they're interested in your project. And if you're thinking of applying for an RFA or a PA, check and see whether they think your project actually sort of meets the vision of the RFA, or whether you're wasting your time submitting. Preferably call with specific questions. People used to call me or come up to me at Society for Neuroscience meeting just to sort of like, you know, cozy up to me, you know, hi, how's it going? How's your week been? And you're like, I'm a busy person, don't pester me. So call with a reason, because if you call just because you want to like buddy up, it is like so blazingly obvious. Okay, so that is all I had to say. I could go on and on about what it takes to write a good grant application, and that is actually what I usually talk about when I give this workshop, and I didn't know how many of you all would actually want to get into the nuts and bolts of that. So if you are planning to submit an application and you want more information, there's my email, and feel free to call. Question?
Okay, so what if you apply for a grant, and since you won't hear about it for 9 months, and then you go out and get other funding, like angel funding or seed funding or something like that, what happens then?
Well, at the time that they would be thinking, NIH would be thinking of making the award, they ask you to let them know what other grants you've gotten, but they don't ask you about, you know, did somebody just hand you a check for $1 million? And if they had, there'd be no way for them to know what you ended up doing with that check for $1 million. It's only if you double dip on grants. You have 2 grants that are doing sort of similar things, and you end up having people like on the same budgets that you get into problems with that. So if you get the NIH grant and you also have $1 million you got from somewhere else, just put the $1 million and just do something else with it.
Keep it.
Yeah, put it in the bank.
Does that happen a lot? Do you see that happen?
So when I was at NIH, I didn't have that many SBIRs. I dealt mostly with basic research grants, and occasionally people would get 2 grants for the same thing, and we were supposed to closely monitor, is there overlap? And sometimes there was, and most of the time people ended up getting away with it, because basically, basically they just want to get the research done. They don't think people are. It's not like professors are using money to, if they have extra money, they're not taking cruises to the South Pacific with it, right? They're using it to support their labs. So, yeah.
Is there any acknowledgement channel, meaning, let's say they decide to reject your application, do they come back to you and tell you that it's been rejected because of these?
Oh, yes, I should have said that. That's important. So yes, after your grant is reviewed, you get back a critique from the studies section. So they send you a thing saying, reviewer number 1 said this, that, and the other, you were strong in this area, and they have criteria by which they're supposed to judge the application, which are innovativeness, the strength of the approach, whether it's logical or not, the principal investigator, what their track record and credentials are, the environment, that would be the institution or company you're working for, and there's a 5th that it's not coming to me right now, but so they have specific review criteria. They must address them in the review, and you get back the review saying reviewer 1, reviewer 2, reviewer 3. Now the reviewers are anonymous, but you also get back the roster of the study section that says who the reviewers were. So
Is that okay that if you don't hear anything from them, to reach out to them and ask them what happened?
Oh, they automatically,
Because in my experience, I had received nothing on CAPS, so I was.
you submitted a grant, and
Yeah.
are you sure that it got into, so first, when you submit a grant, you should get acknowledgement of receipt, which is now like all electronic. Then you get an announcement saying what institute and study section you were assigned to, at which point, if you aren't happy with those, you can intervene. Then they tell you when the review date is going to be. You should get your score back within 48 to 72 hours after the review is done, and you're supposed to get your summary statement back around a month after that.
Yeah, I did it a long time ago. It was all manual at that time, so I'm
Uh-huh. Yeah.
Hi.
One more question.
Two questions. First one is, for someone that hasn't written a grant before, is there a good reference site you could recommend? I'm sure there's probably that you could Google, but is there one that stands out?
For helping write grants, there are a couple of books. If you email me, I can send them to you. They're not SBIR specific. The QB3 program has an SBIR grant writing workshop, which is actually ongoing right now. I don't know how often.
QB3 is a part of UCSF.
Oh, yeah. So you can go there. Yes, there are websites. I can't.
I'll email you.
Yeah.
And my second question is for small business owners that are veterans, prior service. Do you know if there's any special grants for veterans?
I don't know that. Again, that's the kind of thing I could look up.
One more, that's it.
Okay, we'll make it pretty quick. So I guess I'd heard from other people that applying for SBIR grants, there are actually a lot of large companies that spin off smaller startups of their own that then
Pretend to be small.
better chance of getting, pretend to be small and actually have a better chance of getting funded that way. But has that been your experience? And that might have applied more for other institutes than NIH.
As I said, I didn't have that many SBIR grants when I was at NIH. Right now I'm helping companies write SBIRs, but I'm no longer, I used to be on the dark side. I knew all the, the secrets, but I didn't have that many grants when I was there, so I don't know the answer to that question.
Great, thank you very much.
Thank you.
See you next time. Thank you for coming.